to talk just a little bit about decision making to give blood, and then we don't really do the 15 minutes check for a reaction, give another 10 cc's. We're all in bolus mode. But when we talk about damage control resuscitation, and the terms get used a lot, DCR and DCS with obviously damage control surgery. Damage control resuscitation is all about controlling the source if it's external and transfusion. So it's not really new, just the way we do it is. So they tried animal-to-animal blood transfusion in 1665, so almost 400 years ago. And I've got no clue how that went. Little documentation on it. They did animal-to-human transfusions reactions in 1667. And again, little documentation, but I have a pretty safe assumption about how that went. And then you notice a large gap. So again, I use that as circumstantial evidence to the animal-to-human was not successful. Human-to-human in 1818, and we started learning about ABO typing in the 1900s. If you look, RH typing didn't come about until the 1940s, but we were given whole blood back in World War I. So we were doing it during World War I. It was successful, and then we kept learning more, and eventually it fell off the radar. Usually it was either cost or just supply chain related. It's exponentially less expensive to give normal saline than it is to give blood. So from 2003 to 2012, 14% of our admitted patients from OIF and OEF received a transfusion. And of that little bit, 35% received a massive transfusion. So 35% of 14%, really you're looking somewhere around 5% of our patients were receiving a massive transfusion. And then by 2011, obviously that wave was going up, and the massive transfusion rate reached approximately 50%. So yes, injury scores were getting worse, but we were starting to replace LR and normal saline and Hextend with blood products. So we were using more of it, and we noticed, hey, there's a decreased mortality rate. Who'd have thought? Blood replacing blood. So CENTCOM changed the DCR practice, bleeding control, just like we talked about, limited use of crystalloids with CPG. Okay. The early use of TXA with the CPGs assisting provided guidance for calcium with blood administration, looking at preventing acidosis, hypothermia, so going into that triad of death, expeditious transport to surgery, but not necessarily definitive surgery, and pre-hospital use of blood products. So who is least likely? We need to put ranks on here. Captain Battles. When do you think pre-hospital blood really took off?
I really don't know. Pre-hospital blood, I really have no idea.
So it took a few years for someone to say, you know what, we don't need a direct oversight physician. We can give blood safely pre-hospital. So in 2012, 25th Aviation Brigade, their medevac pioneered what we now know as the vampire protocol. So they were the first to do that, and we had been pushing some limited blood use forward with the special operations communities, but the 2012 medevac deployment in RC Southwest is what brought us Vampire. So it proved that we can do it, and we can do it safely. So the logistics of whole blood. So whole blood is the best. we were talking yesterday about blood banking being draw the blood, walk past the centrifuge, put the whole blood in the fridge, and then give whole blood because it is the best. If it's screened, you have lower, but there is still a risk of transfusion-transmitted diseases. If you can give type-specific whole blood, obviously that is best. But we can also use low-titer Group O whole blood, and that's that little 5-letter acronym you see there. So, Captain Schuler, can you explain to me titers?
Can I explain what titer is?
Yes, sir.
It's too early. That's not the negative positive titer. Is the
close? You either have it or you don't.
You talking about positive, negative? No.
So when we talk about titers, so everybody knows about the groups, right? A, B, and O.
Oh, there you go.
And then we know about rhesus factors being positive or negative. But there are over 100 different titers. So I can be O positive, and Major Speed can be O positive. And for some reason, when she accepts my blood, she has a reaction. And we're like, why? And they go back and look, and I have high titers of either other groups or I've been exposed to other A blood or B blood, and I've built up those antibodies, and I'm more likely to trigger a reaction. So we look at pre-screening for people with low titers. So somebody that has never been exposed to A or B or any other antigen-producing antibody, and we're like, hey, their blood's pretty safe. So that's who we're going to depend on to give us blood. We need an Eldon card, preferably 2. I never trust just 1. And we need lab capabilities that may delay. So that's why we're using the Eldon card, and that's why we're using the low titer Group O whole blood. So if we store it in CDP, we can store it for 21 days. If we store it in CPDA1, which just adds adenine, then we can store it for 35 days. Or we can use the walking blood bank. Somebody shoot me a thumbs up if you've ever used a walking blood bank. No one? Okay. Captain Wynn. Oh, we got one? Major Rose, can you talk to me about your walking blood bank?
Kind of. It was a long time ago. It was in 2011 at Camp Dwyer. I was not in charge of running it or anything. Like, in fact, I was in med-surg. I didn't even give any of it. I just know that we did it during a mass cal at one point. And we did have it, well established ahead of time who was in charge of doing it. They were well trained. We had kits for it. And that's about, I don't know how much blood we took at that time. I know we had 16 patients, so I don't know how much blood we actually collected.
Yeah, so a walking blood bank is a great way to get warmed, fresh, whole blood, right? Everything's fun there on the edge of the Hellman, so spent a good amount of time at Dwyer. But so with walking blood banks, so I can pre-screen my donors. I can say, all right, and then, or I can say, hey, you guys have been screened, and we do that every 30 days or 60 days or 90 days, whoever wants to set up the walking blood bank, and say, come over to the loudspeaker and say, hey, I need a walking blood bank because we do have, in your example, a 16-person mass cal, and they show up when we start drawing blood. So that blood is fresh, right? So the longer we store blood, the less oxygen carrying capacity it has, the more the citrate is bound, so the more likely we are to have cardiac dysrhythmias and things like that. So fresh whole blood is best. And right behind fresh whole blood is stored whole blood. So if you do that walking blood bank and you wind up with 20 units left over, like, all right, I'm going to take those. I'm going to either store them with CPD or CPDA, and we're going to put them in the fridge, and we're going to give stored whole blood. So it gives our physiologic ratio of 1 to 1 to 1, right? I can do additional testing. I can say, yep, we pre-screen this donor. Now it's going to be stored whole blood. Let me use the lab right, to make sure that blood really is one, make sure that it really is O blood, make sure the titer screens haven't changed, make sure there's no transmissible diseases. So we can do all of that. And just to point out, your walk-in blood bank doesn't have to be all O donors. You can also pre-screen your A's and your ABs and say, hey, I need this type of blood, and just call those. PRBCs, FFP, and platelets. So if you don't have whole blood, then we're going to give 1 to 1 to 1. So when they looked at this, they studied the more traditional method of we're going to give all the RBCs and throw in a plasma every 4th unit or 5th unit or whenever we feel like it. And every so often we'll throw in some platelets. And what we've learned over the years is as close as you can get it to 1 to 1 to 1 to whole blood, it drastically drops your mortality rate. The benefit of doing components is that you can optimize storage for each of them. So I can take my platelets and store them separately from my RBCs. So I get 35 to 42 days out of my RBCs, whereas I may get a week, a month, or longer out of my platelets. So PRBCs, so there we see 42 days. We don't have any Navy in this class, but if we did, then they could talk about the glycerol cryoprotectant, and we can store RBCs for 10 years. The downside is it takes an hour and a half to prepare, so it's not the sole source of blood you want to use. I've never done it, but talking to some of the Navy guys that are underway, they'll start preparing this as they roll out. So it's good for 10 years. And once you take the cryo or the glycerol out, because it has to be deglycerolized, it's good for 14 days. So when they roll out, they'll start doing units every day and then basically start a rolling stock as they're gone. If they don't use it, it's lost. O negative, PRBC is what we consider to be universal. You'll also see units flying with O positive. Starts Rogers. Why is O positive acceptable?
Because it's the universal donor.
O positive.
I don't know the answer to that.
Okay. Major Manzo. Why would O positive be an acceptable universal blood in our population?
I also do not know the answer to that. I'm sorry.
No, it's fine. All right, so we've all grown up in the medicine world of saying O negative is universal, right? The people who are going to have rhesus reactions are people who have been are negative patients who have been exposed to a positive antigen. So mothers who have had differing blood type babies, or people who have had previous transfusions. The gross majority of patients that we pick up are, up until 20 minutes ago, healthy fighting age males. So a lot of your medevacs will be issued O positive blood. So my entire time I was in Afghanistan this last deployment, all we had was O positive PRBCs. And we've just weighed the odds of this is what we have, this is what we can use. Most of our patients can accept it. I'm sorry, your little name tags don't have ranks on them, but Rosales, captain type. What happens if I give O positive blood to either a cross-exposed mother or somebody that's had a previous transfusion?
They could have a possible reaction because I know from my experience, we try to give females all O negative.
Mm-hmm.
So they could have a possible reaction to the antigen.
All right. How long does that action take, that reaction?
You mean to start the reaction, or
yeah,
it could be,
yeah.
I'm not sure if it's automatic. It could be within a few hours.
Okay. So that is our other kind of safety. We say, hey, I had to give this young lady O positive blood. Most of the time, you're only going to give 1, maybe 2 units because that's all you have. And then you give ROGAM when you get to the receiving facility. So if you get issued O positive blood and you have that female service member in front of you that is very likely to die without a blood transfusion, don't weigh, her possible future pregnancy against saving her life right now. That makes sense? So plasma, we can store it frozen and then thaw it when we need it, or we can just refrigerate it for 5 days. If we put it in a CDP or CPD, it's not frozen, and we can store it for almost a month. If we put it in a CPDA1, then we can store it for 40 days. Thawed, liquid, interchangeable, group AB is universal. Again, we can get by with group A. Sergeant Dumont, why is AB universal on plasma?
I'm actually not 100% certain on that one.
Can I get a thumbs up from anybody that wants to try? Captain Rosales. Got it. Close. So your antibodies, right, are carried in your plasma. So if your patient or your donor is group AB blood, then they can't have antibodies to A or B, and there is no anti-O to speak of. So that's fine. So you're right. So they can't attack self, so their plasma does not have the antibodies. That's right. So freeze-dried plasma or spray-dried plasma. So Italy and France have these. Our SOCOM partners do. And we're trying to push them a little further forward. If we got plasma, then we can have albumin, which is a natural colloid. It's going to bring some of that leaked fluid back to where it needs to go. It can replace your clotting factors. With the colloids, you get the volume expansion. And if we can freeze dry it or spray dry it, then we can carry it further forward. All right, and platelets. We did not typically fly with platelets. One, we cannot guarantee their agitation, and we don't have the proper storage for them. So what we would do is carry plasma or whole blood or RBCs, give either whole blood or 1-to-1, and then catch up on the platelets when we get to the level 2. It's not a lot of volume. It's usually less than 100 cc's. Basically, we're looking for hemostasis, right? So has anybody ever seen a TEG test or a thromboelastogram? Oh. So basically, it's a test where they take a drop of blood and drop it, put a little needle in it, and spin it, and it can tell you, are you short of platelets? Are you dissolving your clots too rapidly? If you see a TEG downrange, then that may be an indication that you need to catch up on your platelets. So this is the stuff you guys really need to know. When to give a blood product. So severe injury patterns above the knee, trauma amps, especially if associated with a pelvic injury, proximal, bilateral, or multiple amputations. So those top two, those are automatic inclusion criteria for blood administration. Be careful saying vampire because vampire is a CENTCOM protocol. So if you go to EndoPaycom or Paycom and you're like, hey, I'm following vampire, they're like, yeah, we don't do that here. But they will do blood administration. So if your 9-line drops and you hear bilateral amps or above the knee amp or any of that, go ahead and use your blood tube and spike your saline, get your warmer on there, and get ready because you're about to give some blood. There's clinically obvious penetrating injury to the chest or abdomen, any uncontrolled hemorrhage. Most of you are going to fly with a partner. That's the role of the ECCN. So if you've got one patient in front of you with uncontrolled hemorrhage and your medic's going to town trying to get that bleeding under control, you got to keep them alive and kind of play that quasi-resuscitationist role and start getting some blood product going. Severe trauma with altered mental status or weak or absent radial pulses, that's a sign of very poor perfusion. So we need to correct that. So you get them in, everything looks okay. You got some tourniquets on. They only had a single amputation, but they had been laying out there for a while, and now you start getting clinical signs. So 100 is the only number you need to know. So a systolic less than 100, pulse greater than 100, and look for the other reasons real quick. Okay, so if their pulse is greater than 100, but their blood pressure is 138 and they're screaming, and they can tell you where they're at, it may not be poor perfusion. It may just be pain. So you treat the pain, you re-cage your vital signs. You're like, all right, we're okay. Cool extremities, delayed cap refill. Don't overlook the simple things. If you had an IV site that was doing fine and now it's weeping, or if they're weeping from like ducts or things like that, maybe look at signs of coagulopathy and treat those as you need to. These are the advanced indicators. So if you're picking up at a rule 1, they may have some of this already done. So a positive fast, especially if you get 2 or more fast, lactate greater than 4, base deficit greater than 6, pH less than 7.25, or a increased INR. Prior to the blood administration, you need to make sure the blood that you place is going to stay there, right? So control the bleeding, control the airway, have to have access, treat the hypothermia, and then use normal saline or plasma light to prime your IV tubing. They do make a tubing that you don't prime, but that's not typically in our sets, kits, and outfits. So use normal saline or plasma light. Don't use ringers. There is very minimal but reportable instances of the calcium in LR binding with blood. So use your normal saline or your plasma light. Prime your tubing. Hook up your blood. When you get here, if you've never had the chance to take blood, we're going to walk through that and give you a demonstration. This is the order of precedence for the blood product. So I think we beat this one enough. Whole blood, either fresh or stored, we need to give blood. If we can't meet that, then we're going 1-to-1-to-1 with FFP, platelets, and RBCs. If we can't meet that, we're going 1-to-1 with what we have. At the end, we're just giving blood product. Remember to use a warmer. Keep the patient warm as well. All of our blood products are stored cold. Warm it up. A couple of adjuncts. So TXA, anti-fibrinolytic that stabilize the clots that you have. Think of it as kind of the opposite of aspirin. So it's not going to make you clot more. It's going to make you sustain the clots that you have. If they meet the signs and symptoms for DCR, then they get TXA. A technique that we used in my company was to put our TXA in the top of our blood box with our blood tubing. So when we pulled our blood tubing out, we had TXA in our hand. And that was kind of our instinctive reminder. If I'm giving blood, I'm giving TXA. Give it within 3 hours of injury. If you delay after 3 hours of injury, then all of the good benefits are outweighed by the actual increase in mortality. Don't kind of get in that wheelhouse of, well, you know what, we forgot it. It's only been 3 or 4 or 5 hours. I'm going to go ahead and give this and just say I gave it earlier. Don't do that. Some of you may have heard about giving bolus dose or IM injections of TXA. There are some places that do that. Right now, the CPGs and the SMOG both say 1 gram in 100 mils administered over 10 minutes. All right, and then calcium. Calcium is like the poor man's inotrope, but it's also lost when we start giving massive transfusion. So the citrate in the blood product will bind to the calcium, calcium citrate. But then that ionized calcium is no longer available for use in muscle tissue or cardiac rhythm or anything. So what it says, monitor the serum calcium, and you absolutely should. But remember that calcium's not going away; it's just bound to. It's not available for use. So if you do a total cal, it's going to read about the same. You need to check an iCal, see what's available for use. And so if you give 1 unit of blood, you're going to give either a gram of calcium chloride or 30 mils of calcium gluconate. So the calcium chloride being basically already in ionized form is immediately available for use. That's why we're giving less volume of that. The calcium gluconate has to be metabolized. If you think about it, if you've already got somebody that has really, really poor perfusion, their metabolism is already out of whack, you may not see the immediate benefits of calcium if you're giving gluconate. So talk about different patients. Responders make you feel like you did something. Non-responders make you feel like you did something wrong. So a responder is you give them a unit of blood, everything looks fine. Maybe you give them some ketamine or some fentanyl, they give you the thumbs up, they give you a high five, and they're going to make it no matter what. The transient responder has the slow leak somewhere, so they improve a little bit, and then they decline again. If they do that, then you need to reassess for your bleeding, reassess for hypothermia, go back and check, hey, did I give my TXA, did I give my calcium? And non-responders are the ones that you're going to pour resources into. So you're reassessing, giving all of your blood products, decompress the chest on both sides to ensure it's not a tension developing. And then if you have more than one patient, triage. Okay, if I've got a guy that if I can give him 1 unit of blood, he's going to make it. I can give this guy all the blood in the world, and he's not. So triage for the greater good. Our goal is a palpable radial pulse if that is the only metric that you have available. We also want to see improved mental status. We want to see a MAP greater than 60 and say, hey, we're avoiding some of those hypoperfusion issues. We also want to see some urine output, hematocrit improving, lactate decreasing, and our base excess or base deficit returning back to that 0 range. So the first step for all reactions is to stop the transfusion. A febrile reaction, an increase in 1 degree Celsius or 2 degrees Fahrenheit. Some people will do this regardless. So in some locations, they will prophylactically give an NSAID like Tylenol or IV paracetamol and preempt that. But then you have to weigh the balance. If it's a 3-hour transport or even a 30-minute transport and this service member is going to perish before you get them there if they don't have a transfusion, then you have to weigh the risk. Is this an actual reaction or is this just non-hemolytic reaction and we're going to be okay? If it really is being detrimental, I don't know what happened there. If it really is being detrimental, stop the reaction, give some normal saline, get some urine output cleared out of the kidneys, and give your NSAID. If it's anaphylaxis, you will notice it. It will be fast. It will be even worse hypotension, maybe some angioedema, and maybe some respiratory distress. The difficulty is we're adding a shock on top of a shock. So differentiating between the two can be kind of challenging. If it is anaphylaxis, then we're going to give the epinephrine, the normal saline, the Benadryl, the steroids, the albuterol. trolley and taco, these are things that the patient didn't do. We did it by over-resuscitation. So the leading cause of transfusion-associated mortality is trolley. Okay, so we gave too much. They started getting some, drew a blank there, like edema. What's that word I'm looking for? Pulmonary edema? Yeah, that's right. And then they get hypoxic. They get less gas exchange, so hypercarbic. They're going to get the fever, the hypotension, cyanosis, obviously, just everything bad. So those patients need diureses that we really don't do in flight. There we go. Taco is we gave them so much that eventually it's going to lead to the pulmonary edema that's going to lead to trolley. So diuretics, which we're not going to play that game, position them as best we can and give supportive care. So we have an airway, give them some O2, BiPAP or CPAP or PEEP if they're on the vent. We want to push that edema back out. And again, get them somewhere that can do some controlled diuresis. This is the handy-dandy little chart, which basically all starts with stop the transfusion, control the airway if you need to. If it's anaphylaxis, you guys all know how to treat that. But basically, it all ends with notify the blood bank. Because if you gave a patient a few units of blood and everything is good, and then you give them one and they have an anaphylactic reaction to it, it's not their body. It may be that tainted unit of blood. So all of the bags go with the patient. So one, they can track, and two, if they need to pull a lot, because if you take the RBCs from one patient, that patient's platelets may be in another bag that they need to go track down. SF518 is the standard form for blood transfusions. You can put it on a 1380 or a 4700. 518 is the release form. So there is a block on there that says provider release. Our technique was just have our flight surgeon sign it when we got issued the blood, and that is his standing order that says you're going to give this if these conditions are met. Those conditions are laid out for you in this file. 1380 and 4700, we're going to talk about those this afternoon, but those are our patient care records. So anything from point of injury is the 1380, anything beyond that's the 4700, and we're going to put all of the same information on that. You guys have the answers in front of you, but the benefit of whole blood of any kind is it's 1 to 1 to 1. It is real blood. It's replacing everything you lost. And if you don't have whole blood, the optimal ratio is 1 to 1 to 1. These on the screen are the immediate indications for blood products. So really bad amputations, any wound to the torso or the abdomen that just makes you go, oh, wow, that's going to need some blood. Anything uncontrolled or trauma with a head injury. Remember I said 100 is the number you need to know. It's 10 mils of chloride and 30 mils of gluconate. And the map we're looking for is a map of 60. Are there any questions?